Good morning, everyone. Today I'm going to present on analysis of in-hospital surgical outcome undergoing repair for tetralogy of Fallot above 5 years of age. So as we all know, tetralogy of Fallot is a common cyanotic congenital heart disease which require repair during infancy. But some patients, especially in developing country like ours, due to limited access to the resources or delayed diagnosis, these patients present late, beyond 5 years of age. So our study assesses these subset of the patient who present late and with unique challenges. And with unique challenges, I mean chronic cyanosis. So chronic cyanosis may lead to significant aortopulmonary collaterals. So in some patients, these aortopulmonary collaterals may need preoperative coil embolization, and also some patients may also have coagulopathy postoperatively. These patients will have severe right ventricular hypertrophy, which leads to right ventricular diastolic dysfunction in postoperative period. These patients may also have complex pulmonary artery anatomy and restrictive pulmonary valve annulus, which will lead to needing of transannular patch repair along with intracardiac repair. So our study was a retrospective observational study with 262 patients, and study period was January 2016 to 2022. So all patients were of TOF patients with pulmonary stenosis and above 5 years, and we have excluded the patients with pulmonary atresia. So these are the result of our study. The median age was 10 years with an interquartile range of 5.4 to 16 years. Median weight was 22.7 kg with interquartile range of 9.5 to 28.2 kg. 11% of the patient required preoperative coil embolization, and aortic cross-clamp time was 75 minutes plus minus 30 minutes, and CPP time 106 plus minus 30 minutes. We lost 4 patients from our study that comprises of 1.5%. Significant amount of patient required transannular patch repair, but our study suggests that there is no much of the significance or much of the effect of transannular patch repair on the surgical outcome or length of the stay of the patient. Ventilation duration was 2.5 hours. 20% of the patient required branch pulmonary arterioplasty. Around postoperative length of stay was around 5 days. And reintervention rate was also low, around 1.5%, and we followed up these patients for over 3 years. These are the videos for aortopulmonary collaterals. The right side 2 videos shows the aortopulmonary collaterals, and the left side one shows the coiled aortopulmonary collaterals. So we planned for aortopulmonary collateral coil embolization a day before surgery, and in those patients with low baseline saturation, we planned on the day of the surgery as well. This is a graphical representation of the result which I have already shown. Preoperative coil embolization was 11%, and transannular patch was required in 69% of the patient. 30-day mortality rate was 1.5%, and reintervention rate was 1.5%. And branch annuloplasty was required in 20.6% of the patient. So I would conclude that surgical correction of TOF beyond 5 years of age is safe and effective, and this procedure is associated with low mortality and minimal reintervention rate. And our outcome suggests that it is feasible to surgically repair even if the patient present late and with complex anatomical variations. Thank you.
That looks like a very good retrospective analysis, but why did you take 5 years as the cutoff? Any particular reason?
So because below 5 years of age, these patients usually have the infant anatomy. Like very less of the patients will have complications like aortopulmonary collaterals and coagulopathies and other complications. So
I won't agree to that.
What is the rate of transannular patching below 5 years? You have any idea? And the rate of coil embolization below 5 years of age?
So below 5 years of age, very minimal, less than 5 to 10% of patients require coil embolization, and transannular patch repair is also very less. It depends on the anatomy of the pulmonary artery. If it is stenosis, then we have to do the transannular patch repair.
Did we have a comparative analysis of that?
No, sir. I don't have that.
Thank you.
You did the follow-up of these patients.
Yes, sir.
How much percentage of the patients with transannular patch came back with significant pulmonary regurgitation?
Sir, I have not witnessed any patients with pulmonary regurgitation.
Clinically non-significant?
Yes, it was not, there was free PR, but that was not symptomatic. Well, patients were not symptomatic that we have to do any intervention for that.
Thank you.